But we do welcome you, and later we'll give you ways to contact the three of us if you need. Let me just introduce myself very briefly. I'm Bob Phillips, and I coordinate the program of Human Services and Addiction Studies at Eastern New Mexico University in Roswell. And I have been supervised by psychologists, by social workers, and by LADACs. And I also supervise LADACs, LMSWs, BSW students, and LADACs as well. I've been the beneficiary of a lot of good cross-disciplinary or interdisciplinary supervision. Let's see. Slides, there we go. So just a few things that we hope are outcomes from the presentation this morning. We hope we can help you make a distinction between the characteristics of interdisciplinary clinical work and specialized clinical practice, and how that may specifically apply to supervision. We're going to look at the foundational competencies that we think, at least, cut across disciplines and in interdisciplinary supervision. There are certainly some competencies that are specific to the various licenses and credentials and practice domains of people, but there are an awful lot of them that are also appear to cut across those things. So I'll hope to highlight some of those as well. We're going to talk about a few best practices that can be used in everyday practice with supervisees. And if you're somebody who's being supervised, we could certainly encourage you to ask your supervisors to include these kind of practices in what you do. And we want to assess how improved interdisciplinary practice can foster inclusivity. All of us have gotten much more conscious about the need to make our workplaces and our practices inclusive and warm and welcoming for a variety of people. And that would include the people who are working in these places as well as the people who are being served by these places. So we hope that good interdisciplinary supervision can help foster that notion of inclusivity. So these were some of the polling questions. We'll have others later, I think, as well. One thing that we discovered, and I'm not sure that I have a sense of this, I know that supervision as a concept had been around for quite some time, but I really hadn't realized how long ago that term entered into the literature. And the concept of clinical supervision has been around in the literature since at least 1909. So it's a discipline or a pedagogy that is now well over 100 years old. And it's occupying a place of increasing prominence across all mental health disciplines. I can think of no mental health discipline that has not become very concerned with supervision because there's a strong relationship, we think, between supervision and quality of care and eventually patient or client outcomes. And so the teaching and the use of supervision in psychotherapy or in counseling practices has really become what Watkins and others in their article has called a signature pedagogy. And it was just helpful, I think, to remember how long that idea has been around. We did a little Google search for clinical supervision. And if you just search that, you get about 2,700,000 citations. Now, we can't claim to have read them all, but it appears that there are relatively few of them specifically address the topic of interdisciplinary supervision, only about 100,000, which is a tiny fraction of the large literature. So this may be, in fact, it appears to be an emerging idea, and I think because it reflects the things that are more common. I'm not sure even to this extent that in schools of social work or counseling or psychology that there are a lot of formal curricula about teaching interdisciplinary supervision. Most of us are familiar with some training that we get in those programs about being supervisors, but typically, in my experience at least, the training that I got in supervision was mostly to supervise people who were of my same credential tribe and so on. I think the reality is that most of us now are working in a lot of different disciplines, and I think that the need to think about this idea of interdisciplinary supervision presents some new challenges and probably some new mandates for us to think about how we change curriculum in our schools of training and so on. And what I've mentioned so far, although it's clear that some practitioners are siloed, if you will, in settings where they have the same credentials as the people they're supervising, but as from obvious from the poll and just our own experiences as we've discussed this, an increasing number of people are now involved with, work with, and supervise, or being supervised by a mixed type of credentials. You just have to consider in our own state, we have a number of credentials that are typically supervised by a lot of different folks. CPSWs, licensed mental health counselors, licensed professional clinical counselors, LADACs, and LSAAs, all very commonly have supervisors out of those credentials. They may be supervised by psychologists or by clinical social workers or by LPCCs. In some cases, LADACs will supervise others. MSWs will serve BSWs, et cetera. But each of these credentialing and licensing types and certification types really set up their own sort of demands for licensure, for certification, but most of them now offer at least some opportunity for supervision from people that are not necessarily licensed or credentialed. LMSWs are a great example. We saw that a lot of you are, in fact, social work practitioners. And as you may remember, or you will know, up to 30 hours of LMSW supervision can be towards your LCSWs, can be interdisciplinary. You can be supervised by psychologists, for example. I've been the beneficiary of that, and I find that extremely helpful. If I were arguing for changes in this, I would actually argue for greater interdisciplinary supervision. I think that the cross-fertilization that I've experienced professionally by being supervised from a number of different credentialed persons and different persons of backgrounds and experiences has been very helpful to me, and I've really appreciated that. And while I see the need to maintain a focus and an allegiance, if you will, to a certain point of view, such as social work, I also have seen the value of having these mixes of ideas and models and theories and concepts. And certainly we don't have enough of any one kind of thing to go around. And in Mexico, I think we're going to be better off if we talk about ways to share these expertises among ourselves rather than remain siloed. Okay, I will turn this over now to, is it Mika who's going to talk next, or?
That looks like mine.
Yeah.
We'll roll with it. I can't see Mika's face though, so.
Yeah, it's, you know, we didn't have an opportunity. Hi everyone, my name's Mika Tari. I'm in part the executive director for the National Association of Social Workers, the New Mexico chapter. And I also recently started at New Mexico State University as the field coordinator, and so faculty there. And just really appreciate being here with all of you. And I think Bob, in his excitement, ran through some of the slides that I was supposed to present, which is that's fine.
It could happen.
It's a very exciting topic. What can we say? So, but I will certainly please have Dr. Lindsay Smart introduce herself and with her slides. So.
Yeah, well, it's nice to see everybody. I see some folks I haven't seen in a while, and it's nice to see some new faces. I'm Lindsay Smart. I'm a licensed psychologist at the University of New Mexico Clinical Psychology Internship Training Program, where I'm the training director. And another hat that I wear is also with our HSC Office for Diversity, looking at faculty recruitment and retention. And both of those titles, I think, are really important just for the slides and my approach to thinking about interdisciplinary supervision. I come at it from a very learner-focused perspective, and really thinking about how early on in individuals' professions do we start to introduce the value of the wisdom that those from disciplines that aren't the same as those that we trained in can bring to our own training. And then there's the lens of considering diversity as well, and the benefit of helping learners really see not just with the diversity that comes from disciplines, there's also a varying amount of diversity that some disciplines don't have. And so there's an opportunity for learners to get exposure outside of their discipline to groups and ways of thinking that are different than what they might have been exposed to in learning. So my perspective as well in thinking about integrated neighborhoods here is from an academic health center, hospital-like setting, where there are folks who are in social work and nursing and tech and teachers. We have interpreters. We have those who are administrative, checking people in, those making sure that everything is clean and ready to go for next patients. There's so many different disciplines, even if we sort of think outside of professions, that are happening within academic health centers, that it is, even if you're not getting supervision from them, having a perspective of understanding that there are other ways of thinking and understanding things. This is an important thing for our learners to consider. And so, you know, even without being supervised by somebody outside of their discipline, many and more healthcare settings are going to be having multiple disciplines, but all within the same location. Consultation and supervision are some of those gray areas, like where there's overlapping. And I think that would be an interesting piece for us to think about, ask questions about in the chat and during our breakouts as well. Because the consultation role has some elements of supervision that happen in these multidisciplinary settings as well. And really trying to understand the culture of those within settings that we're all working. Does anybody have any thoughts? I'm a very interactive leader. I have a presenter, so I would welcome any questions as I go through these slides. It will be much more enjoyable for all when we're interacting a little bit more.
Well, Lindsay, as I look at this slide, I think about all of the settings that, you know, supervision takes place in, and why we're having this discussion, right? So if you think about in an educational or a medical hospital setting, or particularly in the community behavioral health providers now, where FQHCs have become CMHCs, and if you're not familiar, federally qualified health centers that are also doing community behavioral health. I think that the need and the discussion for inter and intra supervision is necessary in so many settings. I mean, when you talk about human nature and dealing with human beings, one of the basic concepts is, you know, to treat the individual as holistically as possible. So.
Yeah, thank you, Mika. Other thoughts, questions?
I know, my name's Catherine, and I don't know if this equals, anyway, I know 13 years ago, when I began being a peer support worker, where I was working, it was brand new, and the other employees really were pretty disrespectful and didn't really give a damn what I said or what I did. And so the supervision or interdisciplinary supervision was really pretty gross. I think now it's a lot different. I believe it's come a long way compared to what it was then. And we CPSWs are looked at differently than it was then 13 years ago, or 14, it was 2007. So it's hard to have supervision from those who are, I guess, fear-based or really negative towards, I'll just say for myself, that were very negative towards me with my label.
You know, Catherine, thank you so much for bringing that up, and what an important piece of the conversation. And there is still great debate happening in the world of peer work around whether supervision should occur from somebody that has lived experience, or as currently set up in publicly funded systems, that it has to be by an independently licensed clinician. And I think there is great value to both. And, you know, I'm not sure that we'll ever solve the issue, but I so appreciate your perspective, and I appreciate the work that peers do. and the value that they've added to these interdisciplinary teams. And so thank you for sharing that.
Mm-hmm.
I would just like to very quickly add the journey that peer workers and persons with lived experience, also Indigenous workers, community health workers, persons that work in domestic violence programs, and persons that come out of the addictions field, all share one kind of thing in their journey in common, and that is that they didn't come out of traditional academics. They came out of lived experiences. And oftentimes the same stigma that was attached, say, for example, to alcoholism was also attached to alcoholism counselors. And so I think we've come a long way, but I think that there is certainly that legacy of those distinctions between people that got their experience through work in their lived experience of this and the experience of addiction and recovery or mental illness and recovery versus those that come to this from a more academic training perspective. And I think that we've learned how to appreciate and integrate those perspectives. But I sure agree with you, Catherine, that once upon a time that distinction was pretty stark and sometimes certainly less than friendly.
Mm-hmm. Thank you.
Can I piggyback on that? Hi, I'm thinking about, having supervised interdisciplinary for a long time, really trying to figure out how to advocate, how to help your supervisees advocate for themselves as an expert in their field, and also facilitate dialogue with people from other fields. And so I'm thinking about, like, for example, in treatment foster care, when you have CYFD social workers and guardian ad litems and the foster parent and the bio family all in one team, and kind of supporting people to understand what the different roles are, not from an antagonistic place, but from a place of on the client and the family system that they're involved with. And I think that comes up in, medical social work or medical field, with doctors and mental health nurses and whatever. So I don't know if you'll speak to that, but how do we support that we're all here for one purpose, i.e. supporting the family or individuals that we're working with in creating healthy systems? And how do we supervise around that, I guess, is my thought, my question, my conversation that's going on in my brain.
Good conversation. I'm glad you're bringing us into it as well. I think we will touch on it a little bit throughout some of the slides. One thing that I think is important that is touched on in a few minutes is inclusivity and the role that interdisciplinary supervision, especially if we look at introducing it with learners at a much earlier stage in their training, how to understand and value and be more respectful of those who aren't on your team, right? And sometimes it becomes this us versus them sort of mentality, and there's not as much exposure to it in some training programs early on. And so the utility of even just early introduction training wise to graduate programs and interdisciplinary training and models could be beneficial in addressing some of the things that you're talking about. But I think it's a larger conversation. We could dive into that now, or we can look at it as we go. What do you, Bob, Mika, what do you guys think?
No, I'd like to say, well, hi Danielle first, good to see you. And second, you said it actually very well in terms of keeping the focus on the family or the individual or the person in service. And as you work as an interdisciplinary team, having that be your base and always, your home spot to come back to, that really does keep the team focused and keeps, I think, the supervision and how you approach that in line and appropriate. So I think that's an excellent point. And I feel like you answered your own question, but certainly happy to have more of a conversation around it.
Next step is how to implement it.
Yeah, I think where the challenge can come is when there are team members who are responding to the situation out of a personal place rather than a professional objective lens. And then how do you navigate that as a team member, but then as a supervisor, how do you support healthy dynamics on a team I think is always my goal, but I don't know if you'll speak to that or not.
I don't know if we're speaking to that specifically. I mean, I think it was when you touched on like the mentoring, Mika, in your comment, and just thinking again, mentoring, consultation, supervision. There's some fluidity between those three constructs, and you know, in mentoring, we've started to move to more of a model of teams, and that there's various people that sort of help fulfill different learning needs or developmental needs, professional needs of a faculty or a learner. And you know, one thing to think about in the interdisciplinary model is the value of interdisciplinary supervision teams to try to look at different pieces of what you were bringing up, Danielle. Any other thoughts before I think we'll probably circle back to that at different points and get more perspective as we go along. But any other thoughts?
Just that I think another place that may come up is when we start talking about competencies, because I think one of the things that may help increase mutual respect among different providers is to understand that they all have the similar competencies that they want to be trained to and want to acquire. And I think that having specific across teams or across members is also a way to foster some regard for each other.
Why don't we go on to the next slide? Whoever has control over the slides. There we go.
Okay.
Thank you. All right. And this one is like an area of definition. We've got one of the greatest movies of all time here. That one's not up for debate. We're not going to discuss it. It's just a statement. But really, what are we talking about when we talk about supervision and competency? You know, and I was trying to think of an example, trying to find something outside of our fields to understand another layer. And obviously, I think this movie explains life, so we could use this movie as an example as well. But I have young children, and we're going through virtual learning right now with APS. And so I am in various stages of supervision, right? So I'm at home, I have a kindergartner and a fourth grader, and having to supervise to guide them towards something, the ultimate goal being learning of some sort, whatever it is that is supposed to happen on that screen. I have to sort of be around to help problem solve, to help maybe model how to handle frustration, how to create a safe environment in which that learning can happen, and you know, guide decisions that they might be making at various points throughout their virtual learning day. And then when I think of competency, I think of the two very different ways that I have to supervise. I have my kindergartner who is just in the early stages of reading. I have to be there almost all day, right? To sit there, to log in, to go over instructions, to be very explicitly involved. Whereas my fourth grader is able to read and has a lot of independence. And so my supervision of her is slightly different. It's the competencies that she's approaching are ones that my kindergartner hasn't yet started to tackle. And so I felt like it gave me a fresh way to really think about this definitions of supervision and competencies. Competencies are usually defined by our professions in some way. It's fascinating to look at how those competencies are decided, who decides them, who has a seat at the table to decide those, and I think that's probably a whole presentation in and of itself. But this idea that we are supervising to ensure that our professions, those who follow us, are within the area of maintaining patient safety ultimately, and providing the best quality care, and that they're achieving something that also allows them to help others. But I'm curious if others have ways of describing supervision and competency that you'd be interested or willing to share.
Lindsay, I want to say that there's a great conversation happening across the country with social workers and cultural competency and what that means. And when do you actually become culturally competent? And you know, the value that's implied in competency, in that there's an endpoint, that you stop a learning process because you are therefore competent. And so there's this great debate about changing the language around a particular competency in social work to address, you know, cultural humility. Somebody just threw out there. Yeah. And so there's cultural humility, there's cultural responsiveness, there's cultural competence. And so there is a very traditional set of folks that say, you know, competencies doesn't necessarily mean that. It doesn't mean that you become so proficient that you are the subject matter expert, end all to be all, and that's it. And I don't believe that's what was implied in other competencies in the social work practice, but that's what we teach to, and that's, you know, what we supervise to. And for whatever reason, and it's not for whatever reason, obviously with today's current affairs and you know, the social issues that are happening right now, I think that social workers are really looking at, can you absolutely teach and supervise to cultural competence, and what does it mean? So I think it's a great conversation. And to your point, it's exactly who is at the table to decide that, who was at the table to make those competencies and give them value. So it's a great conversation, I think.
And I would just add that competency is not an end state. It's obviously not a thing. It is a process. And we'll kind of look at the evolution of competency as a developmental idea over one's career, in fact.
And I want to share that I feel sad that instead of feeling anger, I feel sad that we get labeled competent or incompetent because of a label. Like, I may have a label CPSW, I believe, based on our experience living and growing up. I may be as competent, like when I was working at this place, I maybe had been as competent as a caseworker, or maybe even sometimes as a therapist, because of my growing up experiences, recovering in AA, OA, and yet because of my label, that judgment of, oh, you're not as competent, we won't listen to you. That's very sad to me, that these labels can get really thrown around. It takes a lot of inner self-confidence to ignore a lot of these labels, you know, and not go by what the outside says, to know what we are individually. I mean, I understand this. Yesterday I did a webinar about competence, humility, and the ones that Mika just said was very interesting. So I just think I have to take it lightly, you know, for a personal agenda.
Yeah. Thank you, Catherine. These are all really good points. And, you know, I think that when you talk about competency, the other side of it is just, there's two sides to it, right? Or it should be on a continuum, but I don't think that's always necessarily how we do think of it. And so I think this idea of really digging deeper into what competency really means can help perhaps highlight the variations that we all have based on our experiences and our training and the whole part of our person, right? We are people and we're professions at the same time. Yeah.
And I'm somehow reminded of that phrase that used to say that a little bit of knowledge is a dangerous thing. But if a little bit of knowledge is a dangerous thing, show me the person who knows so much that they're out of danger.
Yeah.
I feel like I need to sit with that one. There's a lot in that. All right, why don't we go on to the next one? Let's see here. So really looking at, yeah, so there will be some things that are specific among different disciplines, right? So like like I want my surgeon to have some supervision from another surgeon, because I don't think I can perhaps in being able to cut open a body and do it in a safely accurate way. But there are other aspects of being a surgeon that may not necessarily require a surgeon to provide some of those supervision, and that's where we're moving into some of those core foundational areas of supervision. What is it that cross-cuts all of our professions that we can be able to guide each other on, and not have to feel like it is something we can only get from within our own discipline. I don't have a lot to say about that slide. Bob or Mika? Or anyone else? I see you shaking your head, Sandra. You know I'm looking at you. I won't call you out. All right, next slide. Okay, so when we let's look at some of these foundations of clinical supervision. And here is an example of some things that cross-cut a lot of ours, especially a lot of us on this call, things that regardless of our discipline, there are some things that we could expect another discipline to be able to supervise us on. So for example, I think one of the areas around legal and ethical issues. When people think of an example of cross-cutting things that, let's say, a psychologist and a social worker and a peer support worker and a psychiatrist would have to have some foundational knowledge on with regards to legal and ethical issues that they could supervise each other on. Feel free to chat too, if you don't feel like.
So what was the question? What was the question?
So around looking at legal and ethical issues, we're starting to look at what are some things that cross-cut all of our disciplines, things that we all have been trained in and have some knowledge in, or maybe in some sort of component of our discipline. Mandated reporting would be an example. So something that if I were to be working with a psychiatrist fellow as a psychologist, could I or would I be expected to be able to supervise them on how to be a mandated reporter? HIPAA came up. Confidentiality. So it doesn't necessarily mean that I have to be a psychologist to understand some of those competencies and to be able to evaluate whether somebody has the skills and the reasoning in order to arrive at a decision that's safe for a patient around legal and ethical issues. How about some of these other domains? I think that are sometimes a little bit harder. What are some things based on this list that you see in front? And I can read them out loud. I don't know if anybody's on the phone and can't see the screen, but roles and definitions, theories and models, supervisory alliance, modalities, methods and techniques, counselor development, competency or evaluation, contextual and cultural factors, legal and ethical issues, administrative supervision and leadership. I see Destiny said self-care, provider resiliency. So interdisciplinary supervision, a foundational knowledge around how do we take care of ourselves so that we can provide services. What other examples are there?
Well, it's interesting. I saw somebody said dual relationships, and I work with medical providers. They have a completely different definition of dual relationships. So their ethical code says it's a privilege to treat another physician, for instance, and they commonly treat members of the same family. So that was a learning experience for me working in that setting, because that's not something that goes across kind of medical versus behavioral health type of stuff.
Okay. So the foundational, there's something about dual relationships in many of our training and expectations, but the definitions or the ways that they are implemented within professions might be slightly different. Respect, thank you, Catherine. Respect for autonomy, respect for supervisees, roles and definitions, disciplines being able to prescribe, deeply discuss medications, medical topics, and others can't in the same way. So understanding, Claudia, is that more understanding what the other roles are of another discipline?
Yeah, I'm not sure if I hope I understood the question correctly, but just, so I'm a social worker, knowing that I can't tell somebody, you know, to go take this medication or that medication, and knowing that that would be for another discipline, somebody else would have that role.
Mm-hmm. So knowing what, working within our scope of practice. Everybody has some scope of practice, and understanding when to recognize you might be stepping outside of it. Universal human rights. That's a great one. Boundaries and dual relationships in role contexts and settings. Some of those contextual and cultural factors. Great. Bob and Mika, did you have anything you'd like to add about this one?
Of course, many of the same things that we would expect that our supervisees would acquire, I think this assumes that we will have those competencies ourselves. I'm not entirely sure that's always the case. Some people teach, some people do, and some people do both. But ideally, there is a sense that somebody who is trying to help someone be competent, say in a clinical role, has also acquired some clinical competence themselves. But it's one thing to have clinical competency. It's another thing, I think, to try to help somebody else become competent. So I think there are other competencies around supervision in terms of teaching, pedagogy, mentoring, other kinds of things that cut across disciplines as well. Here, just another.
You were actually going to, oh, sorry, Bob.
Just another sort of proposed list of some of these things.
Yeah. I was hoping, Lindsay, you were going to tell a joke about a counselor, a social worker, and
I don't have any jokes about that. Most of my jokes are usually around, again, my children and virtual learning and my lack of competency in doing it, because that's where you need all the humor at this point. I'll make sure to think of one though, unless someone else has one. But I think that I think that the important part about some of these as well, especially if I'm thinking of learners, those early on in their training, is like that how much similarity there are in many areas of our professions that we can also provide some support to each other. And this comes up a little bit in the slide that we talk about inclusivity, but this a building of respect, of recognizing that we have some things that are in common, and as supervisors, it gives us the confidence to feel like we can work with others outside of our discipline. In clinic settings, you know, there's a distinct hierarchy in medical settings, and so some aspects of interdisciplinary supervision can help chip away at that, because of a recognition on the breadth of things that we can actually help each other with as well. All right, let's go on to the next slide. Move all these pictures out of the way. Oh, there we go. We are at it. So this is the inclusivity side, really thinking about the importance or the impact of interdisciplinary work on supervision, on helping. There's an exchange that happens in supervision, right, between the supervision and supervisee. And I think with that interdisciplinary component layered into that exchange, it helps to build a mutual understanding of value within a medical setting, when, you know, kind of in some ways I think touches a little bit on what Catherine was saying, right, that there's value in the perspectives that the different disciplines can bring to the care that patients, the good care that patients deserve within our healthcare settings. the importance of using interdisciplinary supervision to chip at that us versus them mentality, being able to model that for our learners, that we can exchange knowledge with other disciplines and be able to be part of the same healthcare team. Improvement of communication. The more you have an interdisciplinary supervision, you start to learn the language of another profession, which then allows you to make better clinical care and decisions when you're faced with some of that language that you might not have been familiar with. Any other thoughts on inclusivity and interdisciplinary before we move on to the next section? I feel like this is, I think, diverse, obviously, with my other hat of the diversity, equity, inclusion, we're in a healthcare campus, we have nursing, we have population health, we have pharmacy, we have school of medicine, and then we have various other learners that cycle through at an even earlier training stage. And the inclusivity component is tough in a medical setting when there are different disciplines vying for some sort of level of recognition. And so we have an interprofessional education office, which doesn't necessarily look specifically at supervision interdisciplinary, but really about how do we understand and have a different level of working relationship with those outside of our professions. And I think interdisciplinary supervision can play a pretty significant role in reducing some of those obstacles to team-based care and healthcare settings. Thoughts, comments, questions?
I think in the perfect world, just in my perception, in the perfect world, I've been in AA for quite a long time. And so that's where I've learned a lot of my beliefs, that if we were all free of fear, which I think fear motivates a lot of us, fear would keep the ego away. And I think it's the ego that causes the issues between individuals wanting to, that causes the miscommunication between individuals, one wanting to be on top of the other in this in interdisciplinary supervision. If you would just listen to me, then the office would just be so much better, or the administration would just be so much more healthy. And then it gets into, you already said that, me against you or us against them. And I think it's just based on fear. If we could just trust one another, that we all have our own gifts to share with one another in the perfect world.
It's really thoughtful, Catherine. I really like what you're saying. And, I think with fear and power, right? I think if you look at disciplines, there's certainly, I think you can't have a conversation about interdisciplinary care without also in some ways considering aspects of power dynamics that sometimes are at play that have prevented, probably in some capacities, interdisciplinary supervision from happening in many of our professions.
It also seems to me, if you want to speak of fear, and I think that's exactly correct, Catherine, but then you wonder, well, what's the antidote for that? And I think it might be something like, how do we create, through inclusivity, some sense of safety?
Right.
And I do think that supervision can be a very threatening process. It can be seen as a judgmental or an evaluative process, a labeling process, as you've mentioned. And I think it's the great question that we can ask, and how do we create context in which we foster a sense of safety? It's the same. Carl Rogers talked about those necessary therapeutic conditions for clients to do well and to change. And I think as supervisors, we might think about the parallels between those necessary conditions of warmth and safety and genuineness that might also be true, you know, in the supervisory relationship as well. But it seems to me that that's one way to think about that is how do I counter fear by cultivating safety?
Well, that's what it is. We come from fear or trust, and trust equals safety. So that's exactly right. Thank you.
Thank you.
I'm trying to read through the questions at the same time, the comments in the chat. Some good stuff you guys are really adding to this chat here. It's making me think. I can't even respond to some of them because I don't know how to respond to it. I'm not as smart as my name really makes it look. This is empowering choices happening.
She's way smarter than that, actually.
You are. Thank you. All right. Why don't we go on to the next slide and see where we can loop some of these comments in. I think this one might be back to you, Bob.
Well, this is just a graphic of the idea that and I think just in response to a couple of things that have been said, competencies are not in states, they're not fixed quantities, they're not fixed qualities, but they are in fact continua. And none of us are ever fully competent, you know, in anything. We can be competent enough, perhaps, in a number of areas. And I guess the other thing that I would say in regards to the idea of a hierarchy or a stepwise kind of notion about competency development is that you can really have as an ideal the continuing development of these kind of things. And one of the biggest barriers to that, it seems to me, and this has been studied quite a bit, is the idea of complacency. There was a study reported by Scott Miller a while back that said that with as little as 100 hours of practice, therapists across all disciplines tended to feel competent, whatever that meant, and that they became complacent in what they were doing. And it's really quite a stark kind of a indictment, really, about our need to continue to grow and to learn and to not become complacent. A phrase he used in that article was that just because you haven't fallen down in a while since you learned to walk doesn't mean you've become better at walking. So we all do things that are good enough, but we really have to think about how we keep on doing it and how we keep on developing it. And there's lots of interesting parallels with that in the work that's been done on the development of expertise, for example. Eric Erickson developed an idea that it takes the average person about 10,000 hours to develop a primary skill or competence, whether it's playing a guitar or performing a surgical procedure or doing a good reflection in psychotherapy. It may take thousands of hours, not just a few hundred hours, to get quite good at it and to keep getting good at it. So I just think that's the point that you want to make about continuums of competencies there. We probably won't have too much time to talk about these things, but it's just to illustrate that there are, in fact, a lot of good models of supervision, and this particular discussion isn't designed to teach you a particular model, but just to acquaint you with the idea that there are models. And one of them is called the Integrated Developmental Model. It's been around since about the 1980s. There are newer ones, but they're all very, very similar. And again, one thing that all these models have in common is that they understand that competencies develop along a continuum. The idea is that people begin at a novice or a learner level, and they grow into kind of a journeyman level, to use that language, and eventually people become journeyman or competent or expertise or more exemplary. But that's something that cuts across all models, is this sense that it's a developmental process. And I very, very much like to think about supervision in general, and interdisciplinary supervision in particular, as a developmental process, not just not just a fixed idea about something. So these are things that you might want to look at if when you get the handouts. Some of the interdisciplinary competencies that are listed by some of these people who describe models include these kinds of things that you want to orient people to: treatment planning, theoretical orientations, professional ethics. Much of the things that we mentioned earlier that Lindsay facilitated your discussion with are part of these models, and I think that's an important thing. There are, oops, what am I doing here? Let's see. This is just another graphic that describes what some have called transdisciplinary foundations. That's just another synonym for what we're talking about here today. And I think these have a more practical sound to them than some of them. All of us, I think, need to supervise people about how to make effective referrals, how to plan services, how to perform assessment, screening, diagnosis, and evaluation, how to do psychotherapeutic practices or interventions, counseling interventions. All of us need to pay attention to professional and ethical responsibilities and to entrain that in our supervisees. Educational efforts that we make in communities, I think, cut across disciplines. So there are a variety of things that do, I think, cut across disciplines. And I think, again, that can foster a sense of respect that if all of us on a team, regardless of our background, know that we each have to do many of these kind of things and we have to do them well, I think that can increase the professional self-regard and professional respect for each other if we can remember that we all have a basket of the same things that we're expected to do and to do well. Let's see, am I still talking about this, guys, or somebody else want to talk about this? I'm happy to go ahead with that.
I think it's you.
Okay.
But I'll chime in after you go, after I see where you're going with it.
Okay, yeah. Well, I don't know where I'm going with it. Except just to say,
this is an interdisciplinary collaboration, Bob.
That's right. That's right. This is in jazz we call it improvisation. So we're just playing off each other here, which I think is a cool way to do it. If you don't know this, the only reason I point this out is not because I think this is the be-all and end-all of this, but it's a particularly well-developed thing. And I have to say, from my own field, in the addictions counseling field, which is primarily what I've been involved with for most of my career, one of the best products out of that field is this document. And if you don't know this document, and you may not unless you're from the LADAC realm of things, but this has an incredibly clear group of articulations of the competencies. And what's interesting, if you go through this TAP 21 document, as it's called, what you'll see is that 90% of it is entirely cross-disciplinary. Very little in addictions counseling per se is unique to addictions counseling. Some things about psychopharmacology, some things about addictive process, some things about tolerance and withdrawal and management of those things and other sorts of things maybe, but much of the same stuff, whether it's the counseling practices, referral practices, they are really quite universal. So I highly recommend this document for a good look at a very, very clear articulation of competencies in general. And there's a companion to this that's called TAP 21A, which has just as clear descriptions about competencies for supervisors. So it's just another model I would refer you to. The other nice thing that's been developed along the way by Steve Gallen and others that have written this is a nice set of performance assessment rubrics. In our index at the back of these slides, you'll see the links to these resources. But it's possible to use, I think as a best practice, it's possible to use these kind of rubrics to help plan a supervision development plan with the persons that you're supervising. And there is some evidence that when you plan your supervision, just like when you plan your treatment, the outcomes are better. So I think you'll see that that's true. That's just an example of a professional development plan. There are many forms of them or types of them. But if you don't do this with your supervisees, you might give it a try and see if it helps. And we usually find, at least in the training I do, both training of supervisors and the people whom I supervise, it certainly helps keep me as a supervisor more on track if I know what it is that I'm trying to help somebody with and what are the benchmarks and what progress is being made towards those things. So some kind of a supervisory alliance-based professional development plan is a best practice that that I think most of us would recommend, and you can see what that might look like. And those performance assessment rubrics are available, and you can see those in the reference section as well. But that's just an example of a best practice, we think.
And I wanted to chime in one thing before you move on,
Please
just
do.
around the
Sure.
around the documentation. I think when we're thinking, especially if I'm thinking of learners, sometimes the process of even just creating a document together allows us, if I'm supervising a psychiatry fellow, for example, and I'm trying to understand what the supervision relationship will be, and as they're putting it on paper, it allows me to see where I am not understanding exactly what their requirements are, what are some of the things that I may need to learn more about from their profession in order to understand that I'm guiding them in the best practices. So I think it's helpful as a supervisor. I don't know if it's as helpful as a supervisee, and if anybody can provide that context, but if you're providing the supervision for me to have something to go on when I'm not as familiar with the training that the person has already gone through in their discipline. I don't know if anybody's been a supervisee and not found that useful and then can disagree with me, which I welcome. And the interesting thing, I think, India's about to, thanks, Jen. This plan, is there often, Bob, in your experience, when there's a professional development plan for the supervisee, is there things on there that the supervisor puts about what they will be guiding them on? So
there are plans that include, and in those rubrics, actually, there are some additions of these things that will delineate the expectations of the supervisee, and will also articulate the expectations of the supervisor. And those are pretty cool, you know, kinds of development plans as well. This particular document doesn't necessarily do that, but I have certainly seen documents that do, and there'd be no reason why somebody couldn't incorporate that, so that there's kind of a shared responsibility for the development here. And I have seen plans that make good use of saying, this is what the supervisee will do, this is what the supervisor will do, and how we can hold each other accountable for that development.
Thank you. Yeah, no, I've had to also think of where I have needed to get consultation as a supervisor from somebody from the person's discipline in order to ensure that I was, again, sort of addressing things in the way that they needed to be addressed. And so I think that would have been one thing if I did not have a written plan for this particular one, but would have been helpful for it to have been like, you know, this is what the supervisor's responsibilities are in order to understand the discipline.
I think it's a perfectly good thing to include, and there are models. If you do a search for supervision plans or counseling supervision plans or counselor supervision documents, actually, let me mention one thing here where you can find some things like this. There's a wonderful program at Yale called the Yale Program on Supervision, and in the resource section on these slides, you can look that up, and the URL is there. But if you look here, you'll see tools for assessing supervisees, tools for documenting clinical supervision, and you can download those things. I won't take the time to do that here, but from the Yale Program on Supervision, you can absolutely download many of those kinds of contracts, agreements, contracting agreements are here. There's a nice variety of tools there that are listed. If this was something that I had not known about until we started researching for this presentation, but I was so impressed with this. It's called the Yale Program on Supervision, and they've really done a yeoman's job of collecting a lot of great resources, great books, tools for assessing supervisors, tools for assessing supervisees, tools for documenting clinical supervision, and contracting agreements for supervision. So if you don't know about that, I sure hope you check it out. I found it really impressive what they've taken the time and trouble to put out there in the world for us. So that's a great place that you'll find some of the things we were just discussing. Well, is it about time we might have a few minutes in breakout rooms, Jen?
Yeah, I think we should be able to do about 10 minutes in the rooms and then come back and debrief a little. So, so I'm going to put the 2 questions in the chat here for discussion in your rooms. So, you know, when you were a trainee, did you receive formal supervision from someone considered outside of your discipline, and were you satisfied with that supervision? And then also, oh, it says number 4, but it should say number 2. Are you generally satisfied or unsatisfied with the ability of clinicians to receive or provide supervision outside your discipline? What would you do to improve or encourage greater cross-disciplinary supervision? So just building on some of what we've already talked about today so far.
Okay, so welcome back, folks, and I hope that you guys had enough time to talk about the questions. They're pretty significant, so we understand if you didn't quite get to all of them, but so we're going to ask that you volunteer to report out on your group discussion, and we're not going to have any particular order, or I don't know, Jen, are the rooms are numbered, right? Should we go in order, or?
They don't know their room numbers, though.
Okay. Pretty typical. So we'll just go randomly. Who wants to report out first?
I'll go. Our group is from Southeast New Mexico. And we talked about the first question. Most of us had supervision primarily within our discipline. And so one of the things that we talked about was kind of like what was mentioned earlier in the beginning of training, is that there's so much value in interdisciplinary supervision. Like my experience myself, I learned a lot from my LCSW supervisors in my own training. And then in ensuing years since that, I've really learned a lot from my counseling peers as far as things that weren't emphasized as much in my experience. And so I definitely see the value more so now, especially since I didn't have that in my own training, and in our group didn't really have a lot of interdisciplinary training in our supervision early on. And so we're trying to integrate that more with our supervisees at this time.
You're making up for the deprivation that you suffered during your training. I get that. Yeah.
That's great. Anybody else want to go?
I just quickly, to piggyback on some of what Erica said, we talked about how valuable interdisciplinary supervision is, and I've really experienced that being a part of the action team, which is psychologists, and realizing just how much I've learned from other psychologists, and realizing that not, being in social work and maybe counseling fields, I don't think we get the benefit of as much training, like as much time in training as maybe other professions in behavioral health do. And because I've really just learned had a ton of on-the-job training. And so just getting this supervision from psychologists on a different team has been so valuable, and I can bring it back to my own peers. So we talked about the give and take of interdisciplinary.
Thanks,
You mean
Lisa.
the clinical aspect, right? The clinical exposure?
Yeah, well, I'm not sure what you mean.
I'm wondering if you mean that they get more exposure to get to practice the interventions before they actually go out in the field as professionals.
I think, well, I mean, from my experience, my social work program was a very long time ago, and it was only 2 years. And I think just the amount of time that psychologists, maybe in other fields as well, spend in class and then also in the field with more time in practice, you know, I think that's always helpful. So yeah.
Yeah, I agree totally.
You know, it really does speak to one of Bob's slides about, you know, how many resources and references he was able to find for clinical supervision versus when he put interdisciplinary supervision in there. And, you know, the conversation we were having while you guys were in your breakout sessions was, you know, about this is not one of those places where you can, you know, and I use the term, what did I say? Fake until you make it. And it's really, you know, when you're doing interdisciplinary supervision and you're supervising outside of your practice area, you really need to go either with your supervisee and learn what their questions are and what their scope of practice is, and learn what the expectations for that supervisee are. And you know, and I think there's a lot of pressure on clinical supervisors these days to do that cross-disciplinary supervision, which, you know, means that there's a lot of opportunity to learn as well. So I hope that you take advantage of that and that you consider that when you're doing interdisciplinary supervision. So, we're getting towards the end, but we have time for, I think, for a couple more report outs.
Maybe one more.
Maybe one more.
Jen's got us on a tightrope here. We got 1 minute. We need to leave for CEUs. We're kind of unruly. That's the joy of interdisciplinary work. We all have very different timetables. Well, you all can reach us. Also, I think Bob is pulling up our contact information.
You bet.
It's a newer, I think, topic, and one that would be probably worth exploring future ways of digging deeper and getting more specific about interdisciplinary supervision, and from both the learning perspective, how do we start to build this in from the very start.
Questions about the, I'm sorry, Lindsay.
Go ahead.
I'm sorry. I was going to say,
No,
there are
go for
questions
it.
about the presentation itself before we give Jen her 60 seconds of fame.
We're missing a slide that had a couple of other references. We can probably send that out to you as well. And that's the thing that had the New Mexico guide and a few other things that people might want. But before we give Jen the last word, as she most certainly deserves, I would just like to, on behalf of Lindsay and Mika and myself, just say what a pleasure it's been to put this together and to help facilitate this and to listen and learn from you and to share with you. Thank you for being here. We really, really appreciate it.